Hello and welcome to my 517 Fellow Friday series. Today, I'm very excited to talk with Dr. Elena Alawa from True Health Solutions Clinic. Dr. Alawa is a board-certified internist and functional medicine and bioidentical hormone physician specialist. Did I get that right?
Yes, you did.
Close
Thank
enough.
you.
Okay. Thank you
Yes.
so much for joining me today. The first thing that I have to ask you about is something that I hope other people might be interested in knowing about. So, you are a DO, which is different from an MD. How do you explain the difference? Because I always tend to look for a DO for a primary care. And if somebody asks me why, I don't think I could answer that.
All right. Hello, Katrina. Hi, everybody out there. Thank you. I'm grateful to be invited to participate on your podcast. So thank you so much. I'm still a little bit under the weather, so I hope my voice travels and the audience can hear me well.
You
So I
sound great.
trained as a DO. The difference between MD and DO is that doctor of osteopathy physicians, they further get training in osteopathic manipulative treatments. So kind of like what chiropractors do, just taken a few steps, notches further. We shared during the first 2 years the same clinical classes with the MD students because anatomy, physiology, and all the basic sciences are the same, except the MDs did not have this further training into osteopathic treatment. And then we moved on to our clinical years, third and fourth, as medical students. And at the time, there was a difference between whether you were following an allopathic versus an osteopathic residency. And now a lot more hospitals have opened the idea of having joint residencies, so they don't make distinct differentiation between DOs and MDs. Now, as a DO, if you want to choose to go specifically into osteopathic manipulative treatment, then you need to do a dedicated residency in that regard. So that's pretty much the difference. Other than that, I find that science is international and universal. And I really think that they need to universalize, if there is a word like that, to describe the fact that medicine should be the same across state borders and across country lines. So if I speak to a physician in California or in Cambodia, we should be able to speak about the same numbers,
Yeah,
the same things that we considered standard. So we have an apple to apple comparison.
that
We're
makes
not there
sense.
yet. And same with
Right.
EMRs, electronic medical records, they need to be integrated. So we're able to easily share medical information if a patient requests a consult with someone from a different state or from a different country. I really think that should become more universal. But again, we're not there yet.
Okay. So for the most part, if I saw a DO or an MD, I should be getting the same type of care, but maybe a different outlook on things, different perspective.
Yes,
Is that one way to look at it?
that's correct.
Okay.
DOs look at the whole person, so mind, body, and soul. MDs, and don't kill the messenger. I haven't followed an allopathic training, so I'm not really sure if they're um, kind of subscribing to the same patterns, but maybe they just lack that osteopathic training in terms of the osteopathic manipulative treatments. But I think every physician should look at the patient as a whole, not treat the symptoms, not categorize them between systems like these are endocrine systems. And if it's anything related to the heart, well, just go to a cardiologist. And
Mhm.
if you have urinary problems, it just takes you to a urologist, and just compartmentalize everything because all the symptoms are interrelated.
Right.
And the systems, our body systems work together, integrated. Right.
Oh,
So that's the idea of looking as a DO at everything as a whole. And it kind of follows, and that's what reminded me and prompted me to go into functional medicine, because functional medicine looks at all those aspects, mind, body, and soul, and considers the person and not treating the symptoms, not putting a band-aid on every symptom that comes up, but rather look at the root cause that has initiated the reflection of these symptoms.
Okay. You kind of just answered my next question, which was to just better understand what functional medicine means and how that is different from any other, I guess, methods or perspectives that doctors take. So it's really um looking at everything and the root causes, not just how we're presenting our symptoms.
Correct. Symptoms are
Okay.
just a reflection of what's going on in our body. It's our body's way of stating something's wrong with me. And for example, adrenal imbalance can manifest itself with many symptoms, from chemical allergies and recurrent seasonal allergies to fatigue, being just wired and tired at the same time, having sugar cravings, so sweet but also greasy type of foods cravings. There's so many symptoms, and you can just say, well, this is one system and this is another system. So you need to look at it in an integrative way and go back to what is it that is causing these symptoms. So that's what functional medicine does. Looks at the root causes of symptoms, because if you treat the root cause, the trigger, then you eliminate the manifestation of the symptoms. So instead of treating each symptom with a different script
Mhm.
or approach, we look at the root cause, eliminate the root cause, and by default, the symptoms should fade out.
Right. So it sounds like functional medicine is not something that you're going to get when you go to kind of like walk-in clinics and urgent cares, because this sounds like you've got to have more time with a patient to figure out what those root causes are. And like you said, not put those band-aids on, like a lot of the treatment that you can get in the kind of the in and out places. Um, I like this. Okay. So, kind of your specialty with the bioidentical hormone therapy, what what led you down this path? Why did you decide to specialize in this and help patients when they're transitioning during all of these milestones?
My personal experience. So after my third postpartum time, I had a very rough time getting myself back together. And specifically, I started having freezing frontal headaches, forehead type of headaches that led to complete loss of vision. And that was scary. And that was something that I have never dealt with before. I've never had headaches. I've never had migraines. I sympathize with patients who did in the past. But as a conventional medicine physician, I was treating just like everybody else. Here's a script. Let's try a different form of
Right.
headache managing medication, right?
Yep.
So I went to the neurologist, and I had MRIs and I had tests done, and everything came back normal, but it wasn't taking away my headaches. And I was told, well, maybe you're just in perimenopause. Maybe you're just about to, become menopausal at the age of 40. So just getting used to having these symptoms was not something that was very convenient or likable. So I decided to dig deeper. And digging deeper, I figured out that, well, I can specialize and I can help other people. Because if I'm helping myself, think about how many other women have so many other symptoms that resonate with the same root cause, hormone
Yeah.
imbalance. And I know from experience with previous patients, when they were coming in to me, um, to seek help, they weren't specifically stating, I'm in perimenopause or I'm in menopause. They're coming in with a list of symptoms. I feel this, that, and I'm not able to get better. And I have tried various things and I'm just still not getting better. But nobody's looking at the hormones. I don't know why there is this fear of um, correcting a hormone imbalance. And I'd like to throw it out there. If you go to your conventional medicine physician and they find that you have a sluggish thyroid, they put you on thyroid hormone. Well, that's a hormone. And yet
Mhm.
women are so open to taking thyroid medication, but they're not open to taking hormones to correct their imbalance. So that's what led me to specialize and switch my gear from conventional just DO training to functional medicine and bioidentical hormone replacement.
And so how are the hormones that you work with clients that are being replaced, how are those different from some of the other options available? Because you talked about this a little bit at the Lansing Women's Forum, where you're like replicating what our body isn't creating, right? So that's different from other hormone replacement options. Am I understanding that correctly?
Correct.
Okay.
Hormone replacement therapy, also known as HRT, I'm sure people are familiar with that term, is mainly based on synthetic formulations of hormones. Oral contraceptives are synthetic formulation of hormones, but those synthetic formulations have a lot of side effects. Yes, they attach onto the same receptors, but they carry a different type of action in the body. So the idea behind bioidentical hormone replacement is that we are replacing the same hormones that share the same exact biochemical structure with the hormones that we naturally produce. Women and men from the age of about 35 to 40 start naturally weaning of those hormones as the body's preparing to go into menopause and andropause. And that leads to significant symptoms that really alter the quality of life. Night sweats, hot flashes, decreased libido, fatigue, just fatigue that cannot be explained, mood swings, irritability, panic attacks, even in the middle of the night in people that have never had any kind of anxiety or panic attacks. Men are becoming drastically more fatigued. They just drag through the day, or they have performance issues, or they have significant stress that is affecting those hormones from normally acting, or diet that is affecting negatively the effects of those hormones. So instead of going on insulin or on diabetic medications or going on Prozac, Wellbutrin, and benzodiazepines as a means to band-aid those symptoms, because we're not Prozac deficient and we're not really
Mhm.
insulin deficient. We should be treating the root causes.
Right.
So this is where we check the hormones, we correlate with symptoms, and then we initiate treatment. Bioidentical hormones will share the same safety profile and effects as your naturally endogenously produced hormones. So that's the difference between synthetic versus bioidentical. Yes, bioidentical are produced in the lab. They come from a plant base, but that plant base in the process of getting to the final hormone is completely eliminated, and the final product is just the same biochemical structure as the hormones that we naturally produce. As opposed to synthetic, they are created in the lab, but they are look-alike. They are poor wannabes, right? If you want to
Mhm.
be, I don't know, Jennifer Lopez, but I'm not. So
Right.
if I am a wannabe, I'm not going to be the same as the original. So that's the
Yeah.
difference between synthetic versus bioidentical. They attach onto the same receptors, but they carry different functions. They carry a different safety and effect panel.
Amazing. Okay, so you've mentioned perimenopause, menopause, and andropause.
Mhm.
Can you just explain the difference for anyone who is in the dark? Because
Sure.
I think I knew what perimenopause was, and obviously menopause is probably talked about the most. I had to Google andropause because I forgot how you explained it before. So if you could just enlighten us a little bit on those three different things.
Sure. I will start with menopause. In the United States, generally speaking, a woman will go into menopause at about the age of 51 to 52. Menopause is an arbitrary chosen time of 12 months of having no 12 months consecutively of having no menstrual period. Andropause is the equivalent of menopause, but in men.
Okay.
They don't have high levels of estrogen and progesterone like we do, but they have high levels of testosterone. So that testosterone starts dropping for various reasons. So andropause would be the equivalent of menopause for men. Perimenopause is that transition period of anywhere between 2 to 10 years prior to getting to menopause. In that transition period, women may have either heavier bleeds, longer menstrual periods, significant spotting in between periods, or not. They will have scantier bleeding, shorter, lighter, shorter menstrual periods, lighter periods, maybe prolonged periods, meaning instead of being a 28-day cycle, it may be a 45, sometimes 60-day cycle. Or
Mhm.
they may have a period now and none for 3 months. And when he comes back, it's a scanty 2-day, very light type of period. So it can be anywhere and it's different for everybody. We all have different set points for our hormones. So what you may be going through is not what I'm going through, and vice versa. And that is influenced by our external factors, our lifestyle, our environment, pollutants, anything that could clog up our hormone receptors, and stress. Let's not forget about stress that could alter the effects of these hormones. So that transition of 2 to 10 years prior to menopause is considered perimenopause or premenopause.
Okay. So, I feel like women are having children later and later in life in the last few decades. So, have you seen, does that tend to push out menopause, or does that not really affect when those women who are having children in their like mid to late 40s, do they still tend to go through menopause about the same time in their early 50s?
Yeah, there's no difference in when a woman achieves menopause. There are some genetic predispositions towards the age or the average age at which the woman will achieve menopause, but there are a lot of factors that will lead to her speeding her way to menopause or not. Again, I go back to those environmental and lifestyle factors. Stress, endocrine chemical disruptors, all of those things in diet will influence the effects on our hormones. Um, Women going at a higher or an older age to achieve pregnancy, it actually impacts their fertility chances because we are born with a certain set of follicles, and only so many of those are actually going to be maturing and developing and helping a woman become pregnant. But all the other ancillary factors, the environmental factors, will further negatively impact her ability to achieve pregnancy naturally. So a lot of women, and actually men as well, will notice that because of environmental factors, they have difficulty achieving pregnancy, affecting the fertility rates simply because of all this chemical exposure clogging up the receptors, and therefore their hormone levels are coming down. Men are affected, their testosterone levels, the quality of the sperm is decreasing because of the influence of these endocrine disrupting chemicals on their hormones. So it's a matter of, in many cases, it's a matter of changing your environment and your lifestyle in order to improve your fertility. But ability to get to menopause, it's pretty much the same.
Okay. So you mentioned that for women, menopause is kind of like that 12-month period. Is there anything that is the trigger for the andropause? I mean, is there, how do men know that they're in that period? Because they obviously don't menstruate. So what is their change, I guess?
They don't know, and there's no specific way of knowing unless you test. So we
Okay.
need to check their testosterone levels. And for men, it's very simple to do a simple blood test. For insurance purposes, you would need to have two separate blood tests to confirm a lower testosterone level. But you have to go back to figure out, is it age related or is it environmental factors related? Because if you're a 35-year-old male, it is unlikely that you're approaching andropause simply because men have the ability of being fertile and fathering children even late in their life.
Right.
So at age of 35, I would not recommend that you put someone on testosterone simply because the testosterone level is low. Testosterone treatment also decreases their ability to their fertility rates, right? So a 35-year-old, we need to look at the root causes. Is it stress? Is it diet? Is it sleep deprivation? Is it that they have maybe a obstructive sleep apnea? What are those chemicals that potentially medications or environmental factors that could be affecting and driving that testosterone level low?
Huh.
So we look at the root causes. It's where functional medicine comes into play.
Right.
Versus a man in the 60s, in mid 60s, well, they're going to have a natural decline of testosterone. They can still father children at mid 60s, but
Mhm.
nonetheless, you are more prone to associate their low testosterone levels with a degree of andropause. And you still go back to apply functional medicine principles to look at root causes, change, alter, modulate those, and you still don't have improvement, that at that point you can consider testosterone treatment. Always ask patients whether they want to maintain fertility or not, because if they want to maintain fertility, then testosterone shots or creams are not an option.
Right. You might have touched on this a little bit, but I just want to go back. You talked a little bit about um, some of the symptoms that us women might experience during the perimenopause. Is there a period like that for the men where they have any type of outward symptoms that would indicate that they're getting close to andropause, or is it just completely different for them?
I think it is completely different, especially since they do not have a period, a menstrual period. So it's very hard to assess that. A lot of men will have decreased testosterone simply because of a lot of stress and diet factors. And once you improve that, the testosterone levels naturally climb up. So you can really call them andropause, that they're in andropause. And again, it is more age driven. So like I said, I'm not going to call a man with testosterone of 250 at age of 35 being in andropause, but a 65-year-old is going to have a level of testosterone of 250, then yeah, I'm going to call him in andropause.
Gotcha.
So,
Okay.
but the symptoms are, they're going to vary from person to person. Low testosterone levels could also reflect in memory problems, depression. So a male may present to the physician with complaints of depression and be placed on Prozac or Wellbutrin or Cymbalta and some sleep aid because they're not able to sleep through the night, and that further disrupts all that
Mhm.
testosterone negative feedback loop. And we're not really addressing the issue; we're just band-aiding things. So it's
Right.
always good to go to the root causes and figure out what's going on. In the process of figuring that out, yes, check a testosterone level, check an estrogen as well, just to see that conversion from testosterone to estrogen, because males are still going to aromatize and they're going to get some estrogen, but it helps to have a baseline. So for them, I think it's a little simpler to work up the endocrine pathway than for females, but we still go back to root causes.
Right. I feel like when I've had blood work done, like the annual blood work, there's never, by default, there's never thyroid and there's never hormone. And so those are always like extra things that have to be ordered. And I feel like on the hormone side of it, I don't even think my primary care has been able to do that. I've always had to go back to like my OBGYN. Um, any thoughts on why those types of tests are not standard? If it seems so simple to me that if we could go to that root cause, and if a lot of our issues fall back on hormones, why are we not checking for these things more often?
You would think, right?
Something feels wrong to me here.
Sure, you would think, but I don't want to diss the conventional medicine
Right.
realm. It's simply because as allopathic and osteopathic physicians, our medical training lacked any kind of information related to this. And even GYNs, they're surgeons. Okay, they're not hormone specialists. When you go to a GYN, they will place you one. It's not you per se. If a woman brings up these kind of complaints, the GYN is gonna place the woman on some form of oral contraceptive. This is
Mhm.
all they know. Well, if you have side effects, okay, let's try a different brand of oral contraceptives. And then the phone calls are just one after another about the same symptoms that are actually worse than prior to oral contraceptives, simply because it's not addressing their anxiety, their sleep deprivation, their depression, because nothing was done to address the root cause.
Right.
There's a long discussion about the side effects of the oral contraceptives. So it's easy for me to order those tests, maybe because I received that training when I did bioidentical hormones. And there's a lot to train in. There are a lot of minutia details that I have never been exposed to in my conventional osteopathic training. And as a conventional physician, when I was doing internal medicine, outpatient and outpatient, I never checked hormones. And if a woman was close to menopause, all we would do is check hormones and say, yep, they're low. Well, you're in menopause
Right.
and suck it up. Just go home and just like every
Mhm.
other woman went through this. But it's wrong
Right.
because it is a transition period that really negatively affects the quality of life of a woman. And we have interventions to improve that quality of life so they don't feel like they're dragging through 20 years
Yeah.
of misery as opposed to enjoying those 20 years and
Right.
feeling like they were 40s again. And when we do hormonal replacement, we're not trying to turn these women into superwomen, catwomen, these, excessive powers or anything like that. We're trying to bring to the table the lowest amount of hormones that result in elimination of the bothersome symptoms, but also give them the preventative scaffolding to prevent women from developing their first heart attack, to help them avoid osteoporosis, to maintain their genitourinary health and sexual health, as well as mood stability, memory preservation, focus, attention, just prevent them from developing Alzheimer's or Parkinson's and things like that. And it's not a matter of just replacing that estrogen or maybe progesterone. Progesterone should be a must with any bioidentical hormone replacement or any other hormonal therapy replacement. But let's not forget about testosterone. There as many testosterone receptors in the hippocampal area as they are in the prostate gland of a male. And I'm talking about a woman's brain. So
Right.
testosterone is very important about maintaining memory, and maintaining that ability to have a sharp mind, and helps with mood stabilization. So we need to look at testosterone levels. We don't just look at estrogen and progesterone and call it good.
This has been so interesting. Um, okay, before we close out, I'm curious about the process where if somebody wants to get started with you, what does the process look like? And then I guess kind of what's the average amount of time that you spend with someone, or does that just all over the place?
Okay. So the easiest way to contact me is just give me a call.
Okay.
517-898-7832. Yes, I'm local in East Lansing, but I'm telehealth. So I travel to you in Zoom form that is HIPAA compliant. And my first consult is a 2-hour process because there's a lot to discuss. Again, we can trim it up or down depending on the patient's personality. If they want to just be told, I suggest you do this, then we can be done in half an hour. If you want it explained, so you understand why is it that I'm suggesting this, why this is a recommendation and what for, then it could be trimmed even up, uh, upwards from 2
Right.
hours. And then I have a wellness membership simply because hormone or achieving hormone balance is really a marathon. It is not a sprint. A lot of patients are under the impression that you had your appointment, you did blood work or saliva studies or dried urine testing, and you get on this medication and you're done. That's completely erroneous because one woman's need and one man's need is not the same as the next one. We all have that different set point and different needs and different ways of metabolizing these hormones. So we need to always start slow or start low on the dose and go slow to monitor side effects. And that requires constant feedback and staying in touch with the physician. So my wellness monthly membership is about meeting patients where they are. If they need to be seen 3 times a week, that's fine. If they need to be seen 10 times a week, that's fine. And we stay in constant correspondence, whether that's by phone, portal messages, or Zoom. So I think it's very easy to get a hold of me. I also have webinars. I teach or I educate women and men about the importance of hormone health. We have one coming up tomorrow, no, Thursday. It's on the impact of our lifestyle on hormone health, and another one dedicated to hormone balance on March 23rd. Did I answer your
Yeah, no, that's
question?
great.
I,
And I have seen you have in the past, I think, and in the future, collaborating with other practitioners. I think I missed the pelvic floor discussion with Dr. Hurst, which I was kind of bummed about, but I love that you take the time to educate others with the webinars and those events, and even just sharing today. This has been really helpful. I will share all of your contact information in the caption for this video. If anyone is interested in learning more about services, or if you want to schedule a consult, you can reach out to her. She mentioned her phone number, but I'll put it in the caption as well. And then if anyone's interested in being featured on the Follow Friday series, you can send me an email at Katrina@cornerstonelegalplc.com. Thank you so much.